Welcome, everyone, to this webinar, Managing Interpreter Services in Public Health During the Pandemic, Part 2, with guest panelists Yvonne Simpson, Irma Bustamante, Kelly Jenneman, and Michelle Harris. I'm Andrea Henry, and it is my pleasure to host today's webinar. Before we'll begin, let me first just review a few housekeeping items for everyone today. The session is being recorded, and the recording and the slide deck will be posted on the NCIHC website. Everyone joining us today will also receive a link to the recording in an email next week.
Make sure to advance the slide, Andrea.
Oh, thank you. Everyone who attends the live webinar today will receive a certificate of attendance as long as you attend the full duration and are connected to the webinar on your computer or your GoToWebinar app. If you have dialed into the webinar by phone and are not seeing the screen share, we cannot verify your attendance, and as such, we cannot issue a certificate. If you're viewing the recording of this webinar at a later date, please indicate code 3849 when requesting your certificate. Be sure to review the webinar policies on the website for instructions on requesting a certificate after having viewed the recording. Our team will make every effort to issue your certificate within 3 weeks of receiving the request. This webinar has not been approved for continuing education, since it is a panel discussion focused on managers of interpreter services. If you experience any problems with your audio connection, please disconnect the audio and reconnect by using the options on the audio menu of the control panel, as you can see it right now on this slide. Please use the questions box to submit any questions or comments for the panelists. I will share your questions and comments with the panelists during the Q&A period at the end, but please send your questions and comments throughout. And now it is my pleasure to briefly introduce the guest panelists, Yvonne Simpson, Irma Bustamante, Kelly Jenneman, and Michelle Harris. Each panelist works in either a children's hospital or a teaching hospital, and they are based in different areas of the United States. They will each speak for about 15 minutes, and I will give a more detailed introduction of each panelist before they present. We also want to learn a little bit more about you, the attendees, so we'll take a brief poll.
And welcome, everybody. We do have the poll open right now, so you should be seeing that on your slide. And if you could share with us which best describes your current role or job title. And so if you're navigating to the poll, we'll give everybody a chance to view the options and select which one best represents your current role or job title. And I still see the ticker increasing, so we have quite a few votes that are still coming in, or responses, I should say. And it looks like they're starting to pause, so we'll close the poll and share the results in just 5 seconds. Very good, and let's see. Today we have 14% who are joining as a hospital or staff interpreter, 3% hospital hourly interpreter, 6% agency interpreter, 29% freelance independent contractor, and 49% interpreter, supervisor, or manager. Thank you, everybody, for participating in that poll. I'll hide the results then, and we'll bring us back to the PowerPoint slide. And Andrea, you can advance to the next one then. Thank you.
And it is now my pleasure to introduce Michelle. Michelle Harris is the manager of interpreter services at Michigan Medicine. Since 1998, when she transitioned into her role as manager, Michelle has grown the department from 40 volunteer interpreters to 80 trained staff interpreters and translators. Under Michelle's leadership, the program has expanded to include a medical translation division, medical interpreting training academy, and a deaf access program. She is passionate about training and feels that this is the key to providing quality services to patients. Michigan Medicine is a teaching facility with 1,043 beds, with over 46,000 inpatient visits and 2.4 million outpatient visits in over 140 clinics in Southeast Michigan. Interpreter Services supports 10 primary and approximately 60 secondary languages. Michelle has her MBA from Eastern Michigan, or Eastern Michigan University, and her BA in English and Business Administration from Adrian College. Welcome, Michelle.
Hi, thank you for having me today. Here to share with you our crazy COVID experience. Prior to COVID, our department was made up of 80 employees, which was comprised of staff interpreters, temp interpreters and translators, contract sign language interpreters who we tried to treat as staff, and our admin staff. We did mostly in-person interpreting using OPI as a backup. Our patients who were deaf, deafblind, and hard of hearing received in-person interpreters 100% of the time. In the state of Michigan, when COVID began, almost everything shut down. We had a stay-at-home order. And because of this, most of our patient appointments, procedures, and surgeries were canceled. And at Michigan Medicine, we had to consolidate clinics. We also had to preserve PPE, so they wanted only necessary staff in the hospitals and clinics, and they wanted us to try to do everything remotely that possibly could be done. So now we had to take our operations home, and we had no previous remote interpreting set up at all for our interpreters. Our interpreters did have iPads, but some hadn't been updated, some never picked up their iPads, and some were too old to be updated. And then our health system didn't offer virtual visits yet, so that did not help our situation. And everything was changing daily. It was changing hourly. It was absolutely crazy for us. And so to sum it up, basically, everyone was home and we had no way to provide remote interpreting. And we really didn't have any patients to interpret for because almost everything was canceled. So this emoji kind of shows how I felt. Next slide. So the first thing we did was we conducted one-on-one meetings with every interpreter. We checked in with how they were doing. We did an assessment of their home computing situation and internet situation. We created personal continuing education plans and project plans. We then got their iPads updated and replaced them with the correct applications. And we sometimes had to replace the iPads themselves. And then we had the interpreters practice BlueJeans and later Zoom, and they learned all the features, and I made them try to be able to set up a meeting in 30 seconds or less. And then the interpreters were helping each other out, creating tip sheets. They became part of the process of making everything work. And then our ASL interpreters really rocked it. They had to come up with a process to do virtual visits for their patient population. We had just done a pilot for video interpreting. And so we already had contacts available. We had some resources. So they took it further and figured out how to make it work. They distributed the units to areas that were opened. They tested gloves for tactile interpreting. They tested and found Clearview masks, and then we got the Clearview masks added to the master supply order list for their health system so that anyone could order them no matter what unit or clinic they were at. And then they contacted the patients and helped them set up Zoom and BlueJeans on their home devices. They practiced with them. They, if the appointment was virtual, they called to remind them of their appointment. And they also reached out to the clinics and worked with the providers on how to do an appointment with the patients. And then soon, Michigan Medicine rolled out telemedicine. It was real quick because we weren't expecting it for another year or two. And so we got the interpreters trained and they practiced. And again, the interpreters were helping interpreters. And one of the benefits at that time for us was from our end, the virtual visits could only be done on iPads or iPhones. So we already had the iPad. So that was one thing that worked in our favor. And then after that, we created a phone number that was converted to a word and we called it MTERP. So this was a dedicated line for OPI interpreting. And I know a lot of hospitals were already doing this. We were behind on this. And so our interpreters answered the OPI calls before it went to the vendor. And we created MTERP cards that we distributed to staff along with flyers. We sent the information to our command center, and we also sent out emails through different distribution lists. And due to the software required for the interpreters to do phone interpreting, we had to get the interpreters laptops, keyboards, monitor, a mouse, headset, and a Jabber number. And luckily, the health system had already had something set up that was a loan program, which we are still part of the loan program and probably will be keeping. Again, the interpreters had to do more training and practicing, and the interpreters were helping interpreters. And soon the interpreters started even doing reminder calls to the patients. It got confusing because clinics were closed that the regular location the clinic might or a patient might go to, it was a different location. And then some providers were still doing phone visits, some were doing video visits, and it was really confusing. So that was a big help to our patients. And then we created patient access lines. And these were the dedicated phone numbers for patients to call our health system. And again, our interpreters would answer the call first. If they weren't available, it would go to our vendor. Our translation team has not stopped since the first of COVID. They translated the portal information for patients, COVID information. They made videos for our patients. They created pictorial screening tools, and now they're translating the vaccine information. We got our portal in Spanish, so that required a lot of translation. And then we did a ton of translation for our local health department. We felt that this was a way to help get the word out to our patient population. We didn't charge the health department for that.
Wow.
Next slide. At our health system, furloughs, reduction of hours, and redeployment were offered for staff. This was completely optional. 13 of our staff took the furlough and reduction of hours. One offered to be redeployed. And because everything was closed down, the health system lost a lot of money. So to add to the stress we had already, we had to submit an economic recovery plan, AKA budget reductions. So, so it was just very high stress time for us. So putting our staff's mental and physical health first, we took a number of steps. We established team huddles that were multiple times a week, and then we went to weekly. Now we're doing them every other week. We had mental health breaks 3 times a week where the interpreters led these, such as Zumba or a cooking lesson, and they were like 20 minutes to a half hour. We had ethics for lunch monthly. We increased it to weekly, and sometimes it wasn't discussing ethical interpreter issues. It was more how are we doing and what should we do in these situations and how are people feeling? And it was just a supportive situation for all our interpreters. Our recognition team started doing after work virtual events. And then I started a daily update email that went out Monday through Friday at 7 a.m. And it contained several different sections. The first one was what was happening. And then like if I needed help for something, I would put it in there. We had the tip sheets and resources that the supervisors and the interpreters had created. They were links to our MBox where we stored things. We had an event section, and then my favorite part is the kudos section, and anybody could request or could put in a kudos or a thanks to somebody else. And this this is absolutely wonderful because everybody was thanking everybody else, and it made me so happy to be a part of this team. And then the final section was objectives for the day, what they needed to accomplish, because we had so much training and so many new things to do. We increased our newsletters to weekly. I did periodic polls and surveys to check in with the staff, how they're doing, and asking their thoughts on things. We got clear view masks for all our interpreters and safety goggles. In our procedural areas and surgery areas, we had to wear, or the interpreters had to wear N95 masks, so we got those. And we also got like Tupperware storage containers with holes drilled in them so that they could store them. And when we could, we tried to honor those who want to interpret in person versus those who want to interpret remotely. And then when it came time for vaccines, I got an email that said that we were either 1A or 1B in the priority. And so I sent an email back and said, the interpreters sometimes spend more time with the patients than the doctor, so we got to be 1A. And the first week they got the vaccines, they were only going to do 200 to test the process, and they invited one of our interpreters to be one of the 200, so we were very excited about that. And then the emojis on the slide are some of our staff, so I thought it was kind of fun to see how they did them, and a lot of them I could absolutely tell it was them. So next slide. So moving forward, we had just been approved for video interpreting right before COVID, like the week of, and we were able to pick that back up, and we're rolling out that in March, anywhere from March to June. And then 2 weeks ago, we started Facebook groups in 5 languages. In collaboration with our Department of Communications. So these are for our patients. We're going to do some live stream events. Our first one is vaccine information, and it will be a bilingual provider providing that information. And we had one last night for an ASL, and we had a CDI actually do the majority of it. And we're working on tomorrow one for Spanish. And then any minute now, we're going to have web pages in 8 languages, and our ASL page will be all video. And then we're sending out snail mail letters to all our patients, alerting them of these features, just letting them know what's going on. And we've been working with the vaccine clinic for patients, making sure that they address language barriers, how to work with it. And also we have a modesty area for female Muslim patients to get their vaccine. And I'm so glad that they are listening to us. I feel like this whole thing has helped us get so much more than what we were doing before. There were so many barriers before, and now we're getting stuff done that has been taking years. So as a manager, I feel honored to work with such amazing group of people. What made this a success for me was not just everything that we accomplished, but the display of teamwork. Every member of their team shared their strengths, and they were supportive of each other. And I want to publicly thank our supervisors. They were absolutely amazing in this. The interpreters, the translators, the schedulers, our operations manager, they were a true definition of team. Thank you.
Erin, do you have a poll?
I sure do. So we're going to turn our attentions again to another poll question. So if you could take a look on your screen, then you'll see the question there. Since the pandemic began, how is your team primarily working? And looks like we have a very lively group ready to make their selection. So votes are coming in very quickly. Give everybody just a few more seconds to share their feedback on this question. And it looks like the responses are slowing down here, so I'll close out in just 5 seconds. Great, let's take a look at the results. It looks like 24% have been working on site, 5% online, 8% on the phone, 56 a combination of the above, and 8% not working much at all at this time. Thank you everybody for sharing your feedback on that. And Andrea, back to you.
Okay. Well, I'd like to introduce Kelly Jenneman. Kelly is the manager of interpreter services at St. Jude Children's Research Hospital. She is passionate about improving healthcare outcomes and ensuring language access for all patients in a diverse hospital with international reach. Kelly grew up in Southeast Kentucky and earned her BA in Spanish from East Tennessee University. After living in Madrid, Spain for over 5 years, she moved to Memphis, Tennessee, where she worked as a freelance interpreter and translator until joining the Department of Global Pediatric Medicine at St. Jude in 2016. In 2019, Kelly moved to interpreter services at St. Jude and began managing the department in January of 2020. She is currently pursuing her MPH at the University of Memphis, concentrating on social and behavioral health. Welcome, Kelly.
Hi, thanks so much for having me. Like she said, I'm Kelly. We work at a hospital that is a little bit different from some of the other hospitals. We are pediatric. We deal with pediatric cancers and other childhood catastrophic diseases. Um, it's a little bit smaller than I was kind of blown away by the number of staff and patients and everything from Michigan. So this is going to be kind of the other end of the spectrum. We have 8 full-time interpreters, and then I also am an interpreter and help out when needed. 2 PRN interpreters and 1 part-time interpreter that focuses specifically on Arabic. All of our other staff speak Spanish, and we also cover French, Portuguese, Hebrew, Italian, and Catalan in-house. We've never actually had Catalan requested, but we have it if somebody needs it. We have regular office hours from 7 a.m. to 6 p.m. and then an on-call interpreter for emergencies. But we also have video remote interpreting units in every clinic and on every inpatient floor. St. Jude operates a little differently than other children's hospitals in that it does not have a public emergency room. So we have a smaller volume of patients, but we see those patients over and over and over. We do have what's called a medicine room that's kind of just like urgent care, ER for St. Jude specific patients. We only have 77 inpatient beds. That's intentional because we try to keep our patients outpatient as much as possible. We have several housing units. One thing I'm really proud about with St. Jude is that no family pays for any treatment, housing, transportation. Everything is provided for when they come here, so that the parents can focus on taking care of their child and the child getting better. So on an average day outpatient, the clinic in 2020 saw about 214 patients a day. That's a reduction from years in the past, but just to give you an idea, we as an interpreter services department worked with about 425 different patients in 2020. Of those 425, 78 were new patients. So as you can see, we just have a lot of repeat of the same patients over and over.
Mm-hmm.
So that has its own challenges. Some of the things that are difficult about St. Jude is that emotional difficulty. Healthy kids don't come to St. Jude. I mean, unless they're cured and just coming back for their checkups. And so there is an emotional component there because we're seeing the same patient over and over and over. We've seen kids grow up, that those a couple of my employees that have been here for more than 10 years have seen kids, that are graduating from high school now that started when they were like in kindergarten. And so it's difficult to navigate those professional boundaries because there is going to be an emotional connection when you've interpreted for the same kid through cancer and recovery and often relapses and things like that. But there's a high level of acuity. We are doing complex protocol consents. We An average day might go from a complex protocol consent to proton beam therapy to a social work visit to physical therapy. So our interpreters just kind of have to be ready for whatever's going to get thrown at them. We have a word of the day wall in the office that I don't think I've gone 1 week since I started without learning a new word, and a lot of times it's medication names, which are just really fun. There's a lot of social work that we do just because of how we work as a hospital. So that's something that I had a pretty sharp learning curve on when I came onto staff at St. Jude, because as a freelance interpreter, I did a lot of ortho, I did a lot of neuro. I had never worked with a lot of social work before. So that was a little new for us. Our current situation is that we are almost all on campus. We could all be on campus. Half of us are in our actual physical office. The other half are in an overflow site on campus because they're not having classes and trainings and things like that. There was an open training room. So we were able to bring the other half of our interpreters on campus, and they just alternate weeks, which ones are in the office and which ones are in the training room. We have 1 to 2 people working from home right now, depending on the day. We have a little bit of flexibility there, but a lot of providers are working from home. And so the person working from home is taking, if med requests in the chart need to be translated for discharge, or if the nutritionist needs to call someone and it can be done over the phone, the person working at home takes care of that. And so 2020 was an interesting year for me. I started as manager in January of 2020. I think I started January 6th, and the first case of COVID in the US was less than 2 weeks after that. My supervisor, who's been really supportive, um, her words to me and to the department were, for a few months, I started as an interim manager. So for the first few months, we're not going to have any major changes. Don't rock the boat. Let's just keep things running, business as usual. And then, less than 8 weeks later, I'm sitting in a meeting with a couple people from operations trying to figure out how to keep interpreting for our LAP patients in the middle of a pandemic and keep people safe. So the St. Jude has been fantastic, just from an operational standpoint. They were able to get a screening and testing system up and running really, really quickly. We're really fortunate in that we have a lot of labs on campus. We have a bench to bedside model, so that we already had all that lab equipment here on campus, and so some of those labs were devoted specifically now to testing. We get tested. Everyone who's working with patients gets tested once or twice a week, and now everyone who comes on campus is getting tested once or twice a week. So I have a favorite nostril now because it's been so many times. And then they were just able to get that operating so quickly, and HR worked round the clock to come up with codes to be able to put in time for people working at home. Our interpreters were hourly and had never been offered the opportunity to work from home before then. And we had software that we were using at work that we then had to make sure everybody could access at home, and a lot of the same things that Michelle was talking about. We had to make sure everyone had the proper equipment and headsets. In the beginning, we were working mostly remote and only a few people on campus until until the testing protocol was in place and masking, and we knew that we were able to safely bring more on campus. And so then we gradually brought more on campus until we're almost all in person now. Um, a big lesson that I've been learning is just flexibility. It's a new role for me. I have a lot to learn, so I need to ask a lot of questions. um, I've been checking in really often with my supervisor. She's been incredibly supportive and a really good sounding board. We are really fortunate in that the previous manager is still working with us. He stepped down from the manager role so he could actually do what he loves and interpret. So I can just kind of, um, call out, "Hey, Mark, what would you do?" and get his opinion and his ideas on things. Um, the emotional toll on me, and even more so on the interpreters, was hard. We had to learn a lot of flexibility um, in when to step back and when to ask for help, and when to work with our resilience department. We Out of the patients that we saw last year, 423 total patients, we spent 50% of our time with 20 patients. Um, so less than 0.5% of all of the patients that we're seeing. Um, Almost all of those patients were bone marrow transplant patients, and um, 6 of those patients now passed away in 2020. And so there was just a lot of emotional toll, and that was new for me in the role as a manager, that everybody's stressed about COVID, everybody's stressed about what's the work situation going to look like from one week to the next. Oh, and cancer doesn't actually stop during a pandemic. Um, and so dealing with all of those kind of moving parts at the same time was a challenge. Some of the things that helped also, like I said, talking with the previous manager and my supervisor, listening to my department, they have really good ideas. I they came to me with several different ideas about how we could do the rotations a little more efficiently, and starting a work from home rotation once everybody was back on campus, to kind of give people that room to just breathe and take the less intense stuff once in a while, and to pick up the slack on phone calls so we could be on the floor, those of us that are on campus. And constant communication. One of my employees joked that I need to just change my email signature to "until further notice," um, because especially in the beginning, daily emails had to go out with operational changes, like, "Hey, this is how we're doing this today. This is who's at home. This is who's at the office." Um, and to the point that there were so many changes that I would send out our basic operations every day and highlight in red what was different. And this went on for the first couple of months through the pandemic, and it was helpful to be able to go back and look at that. Technology was really important to be able to do this. We launched an online request portal. We're a little behind some other hospitals that we're just now doing that, but in December 2019, um, we launched this request portal online, and so that we have one way for people to request an interpreter and see where all the interpreters are located and how long of a wait they're going to have. We can, at the top of the screen, we could list our hours and our availability. So this helped with, schedules that are changing rapidly and the staffing volume. We were able to let people know really quickly. The most useful part for us was just being able to see in one place where other interpreters were. We had no idea when we launched in December that we were going to need it so badly in 2020, but that paved the way for us to be able to work from home and take a lot of those requests that used to be in person, take those over the phone. Um, and so when it got overloaded, because everybody wants an in-person interpreter, and especially at St. Jude, we're really well staffed for a hospital of our size, so people are used to having an in-person interpreter. So we had a little bit of resistance in the beginning from someone calling them on the phone and saying, "Hey, there's not an in-person interpreter available. Can I do this over the phone for you?" But people get used to things, and and it worked out fairly well. Um, we also were able to integrate with a telehealth app. We use an app called PEXIP or PEX IP. I'm not sure which it's called. The app was introduced and rolled out really quickly, and Interpreter Services was one of the first groups that was trained on how to use the service. And then we worked with our third-party vendor to integrate with PEXIP for languages that are not staffed. So now they're able to do telehealth in any language, not just the ones that we have staffed. We use Microsoft Teams a lot because it's secure. It's encrypted, and so we don't have to worry about PHI being shared and things like that. But also, we can have one location where we can put the work from home rotations, the schedules, the current operating instructions, instructions for all the new technology everybody's working with. And also there's a chat function, so we're able to keep in constant contact with everybody. There were some positive changes from the pandemic. I mean, there were some things that needed to happen that I think happened a lot more quickly just out of necessity. As all of you probably know, people are resistant to change, and especially when it comes to technology, or telling people there is now one way to request interpreters, or telling the interpreters like this is the way that things need to be recorded. That's always going to meet a little bit of resistance. But what I learned is when you're in a time of uncertainty, like with COVID, people want certainty. They want to know exactly this is what I need to do, and if I do this, I'm doing the right thing. And so I feel like we had quicker adoption of the request system than we would have had we not been in a pandemic. And I feel like among our staff, my staff is brilliant, and they would have learned it and they would have done great anyway. I feel like they just took it up about 3 notches as far as how quickly they caught on to all the new things that they needed to learn. And they were just fantastic about it. Another thing that changed for the pandemic for the positive, I think, is communication. Because our team is physically spread out, we've got to be intentional about talking to each other. So for me, that looks like those daily emails every day, letting them know just where people are, anything specific they need to know. From team members at home, letting them know, hey, I'm on lunch. There's nobody taking phone calls right now. And from the team, sending out important updates about a patient. Because we're seeing the same patients over and over, if someone has, relapsed and is, just had a really, really hard appointment, and the next few are going to be really rough, it's good for us to know about that as a team rather than just being blindsided when we walked in. We had been doing this kind of informally as a debrief process in the office, but the problem is if anyone was out of the office, they would miss what's going on. And so changing the process to be a little more formal, where everybody has access to the same information, I think was a change in culture that would have taken a long time to catch on if the issue hadn't kind of been forced by physical distance. So now, even though most of the interpreters are back on campus, we're still continuing that intentional communication, which I really like. The adoption of technology by staff and interpreting staff and hospital staff has been great. And also just the work from home flexibility that our staff didn't have beforehand. In the beginning, when we had so many staff working at home, we were able to meet the demand that we had while staying physically distanced and reserving PPE for the providers. We had an employee that was quarantined who was a close contact, and she was able to continue working from home, and that hadn't been an option before. And so even related to COVID, it helped a lot being able to work from home, but also not related to COVID. Whoever is working from home can focus on those phone requests, so office interpreters are not pulled away from the floor to do things over the phone. So we are able to concentrate more on what we need to be doing in the hospital because someone at home is taking care of the phone. I've also seen increase in employee satisfaction, just having some schedule flexibility of being able to, if someone had a sinkhole open up in their front yard and had to have people come and work on her house. And rather than taking time off, she was able to work from home, which, saved her money. It increased productivity in the department and gave her some, job satisfaction, and that felt like she had a little bit more control over her own schedule. Um, Having a regular rotation of working from home just gives employees a little bit of a respite. They're still working, but they're kind of away from the stress of the hospital. So I am interested to see. I think that hospitals all over the country, especially with jobs that in the past have been seen as only in-person jobs like interpreting in a lot of hospitals, I'm interested to see what happens in the future as far as the way we view work and the way that we view hourly work and what actually can be done remotely. And my hope is that some long-term flexibility comes out of this for interpreters that work in hospitals. Um, I have to brag a lot just to close it out on my department. They have been under so much transition. Um, they went from, they were kind of blindsided by the whole, hey, you're going to have a new manager. And then then there was a pandemic, and then we've had, a couple patients that we've had for a long time get really sick, and some of them pass away, and some really, really difficult situations with patients that we've worked through, and they have just shown resilience time after time after time. They've shown patience with me and with the changing processes, and they've shown flexibility. And I feel like everything I've asked my interpreters to do, they've said absolutely yes, and just jumped in and done it well. Also, I just appreciate the hospital that we work in. We knew we were fortunate to work for such a great institution before the pandemic, but even now it's brought to light how much more fortunate we are than we even realized that we're respected as members of the care team. We were immediately put in that first round with vaccines. All of our interpreters that wanted a vaccine are fully vaccinated. We were kept in the loop on what's going on with operations and changes, and I feel like our interpreters just really have been respected this past year as part of the team that that really adds to comprehensive care of the patient. So I'm super thankful for St. Jude, and I'm super thankful for my staff, and I'm still new at this, so I definitely am going to look at some contacts that I'm making through this, and we'll be reaching out to some of you with questions. Thank you.
Thank you, Kelly. Erin, do you have a poll?
Yeah, we sure do. So again, learning from the experiences and our attendees who are joining today, please take a look at your screen. You should see the poll question there. And as the topic of vaccines have come up already, we'd like to learn from all of you if you have been given access to receive the COVID-19 vaccine. And so whether or not you have actually received it, that would be a different question. We'd just like to know if you've been given the opportunity or access to receive the COVID-19 vaccine. And we'll give everybody a chance to make their selection. And it looks like responses have slowed, so I'll go ahead and close the poll and we'll share the results. Looks like 74% reporting yes, 23% reporting no, and 2% are not sure. Thank you, everybody.
Thank you, Erin. I'd like to introduce Irma Bustamante. Irma is the Manager of Language and Cultural Services at Phoenix Children's Hospital and oversees interpretation and translation services. Phoenix Children's has a medical staff of over 1,000 specialists and provides inpatient, outpatient, trauma, and emergency medicine in more than 75 subspecialties. Irma has over 20 years in interpreter services, including training of interpreters, training of trainers, advocacy for limited English proficient communities for the state of Arizona, and coordinator of multiple interpreter process optimization projects at Phoenix Children's. Irma manages a team of Spanish and American Sign Language interpreters and oversees contracts for interpreters in over 100 languages. Welcome, Irma.
And Irma, we're not getting your audio just yet.
Okay, can you hear me now?
Yes, we can. Thank you.
Oh, perfect, thank you. So good morning and greetings from Phoenix, Arizona. Thank you, Andrea, for that kind introduction. Unfortunately, managing interpreter services in healthcare during the pandemic has become our new normal. However, along with all those challenges, we've had new opportunities. Before I jump into the details, I'd like to tell you a little bit more about our hospital. Next slide. So we have various, if you go straight to the arrow, you'll see that we have various locations. We have two hospitals one is on our main campus in the middle of Phoenix, and another one at Dignity Hospital in one of our suburbs. We have 4 specialty and urgent care centers in the Phoenix metro area, and we have 22 outpatient treatment centers. Our brag is we have amazing centers of excellence at Phoenix Children's Heart Center, our Barrows Neurological Institute, and our Center for Cancer and Blood Disorders. We also have a pediatric orthopedic program that has handled over 107 unique scoliosis spine surgeries for patients that have come from all over the United States and abroad. We have a level 1 pediatric trauma center, and we have a newborn intensive care unit that has children coming not only from Arizona, but from different places in the Southwest. Next slide. So for the past 35 years, Phoenix Children's has brought healing to children throughout Arizona. We are a freestanding, not-for-profit hospital that really depends on the kindness of our community. And what children like to say is, "Mommy, take me to my hospital." And really, the bricks and mortar of all our new developments do come through the generous donations from many, many members of our community. So if you go to number 1, our care, we provide accessible care to many of our patients in our community through 33 primary pediatric specialty clinics. We have 55 subspecialty clinics as well. And we have 433 licensed beds currently at our main campus. Going down to number 2, patients are coming, like I said, from all over the world. We've seen them come from 12 different countries, and 46 different states have been represented, bringing children for the specialty care that we're able to provide. We've done over 17,000 surgical cases. We see around 86,000 plus emergency visits, 52,000 urgent care visits, and over almost 3,000 trauma cases a year. If you move over to number 3, telling you a little bit about our team, we have almost 5,000 employees now with, again, 1,250 total medical staff members and over 1,000 nurses. We are the 27th largest employer in the state of Arizona, and we are very proud of our over almost 5,000 volunteers. Unfortunately, during COVID, our volunteers, for their own safety, we only had a few volunteers working for us, and they're very anxious to come back. Looking down at number 4, let me tell you, we are a teaching hospital with 130 residents in 3 residency programs, and we also have a fellowship program. We have a very robust research program that is supported not only by PCH funded dollars, but through generous donations and grants from our community. We have over 400 research programs. So imagine as we get these new and innovative programs, our interpreters are having to learn new terminology all the time. And some of these words, I can tell you, they're about yay big, and they're even hard to pronounce in English, much less in another language. Also, we have a translation team that has to translate all those research consents. And again, bringing a new level of information to our Spanish-speaking community. Next slide. So let me tell you a little bit about our language services department. I'm the manager of our team. When I came here 22 years ago and was asked to take over the team while I was doing research, I had 3 interpreters and 1 translator. I now have an entire team of almost 30 staff members. Our interpreter team consists of an interpreter supervisor, and this supervisor took on this new role in November after working as an educator. So it's an educator/supervisor role. Our staff interpreters are in Spanish mostly. We have 19 full-time interpreters and 5 PRNs, and we have 2 American Sign Language interpreters that are part of our staff. Most of the time we leverage our work with our vendors, and the top languages that we're covering is Spanish, number 1, then Arabic, Swahili, Vietnamese, Burmese, Rohingya, Kinyarwanda, American Sign Language, and more recently in the last year, we had to find a vendor that would help us with our Mayan dialects for our refugees that are coming from Guatemala. Our translation team consists of a translation coordinator who is also our chief Spanish translator. And Marcela is an MD with multiple master's degrees. She's brilliant, and she can pretty much handle any translation that comes her way because she has all the resources in the world to be able to find the newest branding terminology that we're going to be using going forward on any new thing we're talking about. We also have a translation tech. She uploads all the work through our translation memory software, which again remembers, for those of you who've worked through this, remembers all the work we've translated before so that we can say it again the same way. She also sends all other languages for translation to our vendor, and she translates Spanish discharge instructions during the week. We also have a PRN translator who does our discharge instructions during the weekend. Next slide. So the rest of you, we all had a call to action sometime in March. We had all been asked, like everyone else, is to really look at how we were going to reduce our staff, or not staff, but really our visits, to be able to save that PPE for that service in front that was going to see the patients. So on 3/17, our interpreters, when all of our patients went home and weren't coming into the hospital, our staff interpreters were asked to do conference calls to families. So we were doing over the phone interpreting, literally wherever we could find a phone. Remember, we were all doing in-person interpreting up to this point. And so we had to quickly reconfigure where are we going to find phones where these folks can call folks at home. On 3/23, a group of interpreters were assigned to support outpatient appointments through Zoom. That means the doctors were really having to jump in there and go to do those Zoom calls. And we had, thankfully, due to a process optimization project that we started 3 years ago, our interpreters were able to follow through appointments through our dashboards on their laptops. And they'd already started doing VRI and Zoom clinic visits at 2 satellites. So we had a couple of 2-3 people who were really good at it, at Zoom calls and video remote, and they literally were our champions in teaching the rest of the team. But they also were sometimes standing next to the providers who also were new to this while they Zoomed in a family at home. On 3/24, leadership asked us to formalize interpreter-provider workflows so we could better be able to understand how to do those telehealth appointments. And that's where the real teaching began. At some point after that, we were able to integrate our vendor appointments into Zoom meetings, and we were also able to do other language and then American Sign Language. Next slide. So video remote interpreting was a concept that I'd been thinking about probably for about 4 years. Something that my boss said, be careful what you ask for, because all of a sudden this dream of what we wanted to do, being able to do a call center with VRI, all of a sudden became an initiative for our executive leadership. This year, it turns out that by the end of the year, they wanted to do VRI, but all of a sudden, come March, this was all very much fast track. So we had executive leadership champions, and at the very top of that was our executive vice president, who is also an IT guru. And so we had started, literally, we got together an IT project management team with many, many people from IT and leadership. And we started our first meeting on April 27th. And their goal was to have us ready to go with VRI by end of July. Well, that didn't happen. We actually went live August 12th. We had on this team, like I said, we had IT infrastructure, facilities folks, telecommunications, clinical leadership, and physician leadership. We also had added technology. And boy, we had to find headsets during, as you well know, everyone needed headsets. So there was, supply chain issues there. Luckily, we all had our iPad, our laptops, but those needed upgrades to be able to get into these new platforms we were going to be working through. But what we did was added 82 iPads on a rolling stand. The iPads were easy enough to get, but those rolling stands came from a company that literally had to get pieces, literally little wheels to roll in. They had to come from England. So we had some serious supply chain issues. At the end of the day, our facilities, everybody was helping put these things together. We had them all lined up in a row. I mean, we're working late hours, but by golly, we got this stuff done. And then our probably most important thing, we've been working little by little on broadband improvements, and this kind of fast track saying, hey, we got to get everything done, not only here on main campus, but across the organization. Next slide. So if we were going to be going from in-person to VRI to Zoom, we needed to be in a space that was quiet. We had to find a space that was easy to get to. And so our facilities folks were able to find us 3 spaces in our clinical area where our interpreters who are working the clinics were able to take Zoom calls, and in between Zoom calls, they'd be able to run up to the clinics that were nearby. So again, overall space was something we needed to find. We had short-term space issues, long-term space issues. And at the end of the day, what we found was long-range goal was to send our interpreters to work from home. At the beginning of the pandemic, a lot of our administrative and ancillary staff were sent home. And so it was a long-range goal for us. At the beginning, we all stayed on campus. I have not left campus because there's a lot of things that have to be done here. So currently we have on-site interpreters. We're down to 3 to 4 during the day and 1 at night. And we have 10 working from home Monday through Friday, and they're all working staggered shifts. So this whole process, Ms. Min, has been education, education, education. Through staff meetings. Now we can't see people in person, so we had to Zoom in meetings, right? We had to prepare tip sheets to put on the iPads. We had to, nursing education, use their platforms to send out education to all of nursing. We did quick tips for interpreters, and we did troubleshooting guides for all of that equipment that we were sending out that no one had ever used before. So next slide. So we did this in different phases. I guess phase 1 would be that first call to action. We were able to do outpatient visits through VRI, OPI, and we continue to do in-person appointments for those patients that were still being seen here. And then we were also seeing outpatient clinics as well. We were able to manage this through a dashboard that we had developed several years ago, but it just became more intense. Our inpatient in-person appointments were managed through our dispatcher, and also our vendor was able to leverage. We were able to leverage our vendors through OPI, VRI, and Zoom for our telehealth appointments. Phase 2 pretty much started August 12th, where we started to take care of our full network, and we added a new customer supporting about a bunch of schedulers that were scheduling appointments all over our network. So we also added our dispatcher to the interpreter team because now we were, being able to manage all our work through our dashboard. So we started our in-house call center on main campus, and we also had an ancillary building where we were able to use spaces that were used by IT before, but that those employees had been sent home. We had our laptops that were upgraded, but we also needed monitors and all the IT equipment that came with trying to have the best reception and receptivity that we could have. We did limited in person, and as you can see below, that included ED traumas. We go to those in person, bereavements and end-of-life discussions, and long inpatient family conference meetings. What we did as well is part of the technology was able to get us back. Oh, I think my slide went backwards. Yeah, was to have our new technology forward calls after 5 minutes of holding for interpreters. They went directly to our vendor, and they were able to handle after 5 minutes. Phase 3 of our process was going to our full network. We are now working, we have our full contingent of folks working from home, and we have our staff that are here on main campus in an office here in the main hospital so that they can go to traumas or immediately go to inpatient clinics or inpatient meetings if needed. Again, we're using Zoom, video remote interpreting, OPI, and all this is done on demand. Like I said, we continue to have limited in person, and again, continuing to leverage our VRI capabilities. Next slide. So the results is, wow, we built a call center from the ground up. That was pretty amazing. Again, during this time of COVID, I keep saying, and during the time of COVID, because it's amazing how many things we've gotten done with all the things going on outside and inside as well. We have a really resilient staff, and they had to learn a lot of new stuff. There was a very steep learning curve and a huge expectation so that our families would be able to receive the care they needed in the language that they needed. We had daily huddles initially to be able to troubleshoot every problem as it came along. There were days that some of our interpreters at the beginning were putting like 20 IT tickets in. We wanted all these IT tickets put in so that we could begin to document what are things that are common to the problems happening and what things could IT immediately help us to fix. As of now, we're now currently meeting twice a week, and we're continuing the huddles, and I do a weekly end of the week email for those folks who are not able to get to the huddles. Our technology challenges are getting better every day. The telehealth using Zoom we're using telehealth using Zoom for our outpatient visits. We're using OPI and VRI using Jabber for outpatient and inpatient visits. We work from home. We had the challenges of our internet connections, really working with our IT department to find the best optimal upload speeds for our staff. And then we had daily IT support for all our technology challenges. And we actually had a code in there with IT to immediately help with those issues. We have a fabulous relationship with our IT department. I wouldn't be here before you today if they hadn't really sped up the work to be able to have me here to present for you today. Our overall results, again, the next slide. So, it was decided early on that interpreters would not go to the COVID calls or rooms. This was in order to save the very limited N95 masks that were available, to leave those available for our providers. For our non-COVID in-person calls, interpreters were given goggles, face shields, masks, gowns, and gloves. I have to say, early on, one of the things that I've said is I have felt very safe in our hospital. People say, how do you feel safe in a hospital? Well, I'll tell you why. Because early on, our occupational health, through the help of apps and technology, set up an employee portal where we record daily our daily temperature and any symptoms that we might have related to COVID. I have to tell you, I had a few weeks of bad allergies and they weren't taking any chances. They had me come in and test for COVID twice, and that's not very pleasant. It started early on with nasal swabs, but later on we moved to saliva tests, which were being sent to our local university for testing. We're able to test here on campus. They would have us drive in through a special driving place where we all felt safe and able to come in, and we'd have results on those tests pretty quickly. Also, all of our they limited the patient access. Patients could only come in through one entrance where they had screeners that would screen them for any symptoms and also ask the patients and give them masks if they needed it. Our entrance as employees, we had separate entrances where we're taking our daily temperature coming in, and we were given masks to use for the day. So at the end of the day, oh, and I also have someone from housekeeping walk by my office and clean my doorknob every hour to make sure that those doorknobs are sanitized. Other positive results after we had positive results from our end users a couple of weeks after go live, after doing a monkey survey. We also had our American Sign Languages interpreters added to Zoom calls, not only our PCH PRNs, but also our vendors. And that meant our vendors had to send addendums to their contracts because this was an absolutely new service that they were providing to us. Believe it or not, we had a little dip in productivity at the time in March, but as we became more efficient in the way we're taking calls, our staff interpreter productivity actually went up and our vendor spend went down. Important for us is that our CEO made a decision that we would not be letting go of anyone and there would be no furloughs, and we have kept all our employees. The way we did that is to really take a strong look at how we were using all our vendors and looking at ways that we as employees could do a lot of the work that our vendors had done. We really reduced our vendor spend, and in that way we reassured our staff of keeping their job. At the end of the day, actually people have also asked about our vaccine program before I end. Vaccines were made available not to our interpreters early on through our county facilities. And just last week, our vaccine pod was opened here at Phoenix Children's Hospital for our employees. And so people have really taken advantage of all these opportunities. I just wanted to just say at the end here that we are very pleased with all these changes to be able to do more good for more people, and it not only and beyond our campus. So I just really have to applaud all our hardworking staff, our hardworking leadership to be able to continue to offer the best that we are to our community. Thank you.
Thank you, Irma. I'd like to go ahead and introduce our next panelist. Yvonne Simpson is Director of Interpreter Services at Harborview Medical Center in Seattle. She holds a Master's of Arts in Spanish Linguistics and has significant experience in interpreting, translating, and training interpreters. Yvonne is a certified medical interpreter through the National Board. Formerly, she was an interpreter at St. Joseph's Hospital and Medical Center in Phoenix, Arizona. And currently, she volunteers for Notice, the Pacific Northwest chapter of the ATA. Welcome, Yvonne.
Hi, greetings from the Northwest. Thank you so much for inviting me to participate over the last couple of webinars. It's been so interesting to see the similarities and differences on how we've all responded to the pandemic. And honestly, it's very comforting to hear how others have faced these circumstances. So you can go to the next slide. Harborview is part of UW Medicine. It's a healthcare organization tied to the University of Washington. We are a level 1 trauma center. We're also the county hospital. So our mission population includes persons who are non-English speaking poor, those who are underinsured or uninsured, those who are incarcerated, people who have mental illness, in particular those who are treated involuntarily, people who require specialized emergency or burn care, and several other special populations. Our interpreter services department is very diverse as we serve immigrant and refugee populations in the greater Seattle area. Roughly 20% of patients and their families at Harborview prefer to communicate in a language other than English. So currently our staff speaks a total of 18 different languages, and we see over 100 languages in a given year. In addition to interpretation, our department also has caseworker cultural mediators who are hospital-based community healthcare workers providing navigation and advocacy for their caseload of patients. And we also have Ethnomed, found at ethnomed.org, a web-based educational resource for work in cross-cultural medicine. Previous to the pandemic, our staff provided primarily face-to-face interpreting. We have a small call center in our office that some of our staff rotate through to provide telephonic services. Prior to the pandemic, we did very little video, and many things changed with the pandemic. So next slide, please. Washington State and providers from our hospitals started responding to COVID last year. In fact, last week, we just passed our 365 days of COVID in Washington. And then in March, when the pandemic fully started, our hospital and system focused on addressing needs of the community as well as needs of the hospital. By mid-March, our hospital had started reducing clinic visits or changing them to telemedicine so that employees could be redeployed for other COVID-related care. As many of our in-person encounters dried up, we pivoted to provide large amounts of telephonic services in our already existing internal call center. We started providing video interpretation, and we, in fact, redeployed some interpreters to other roles. One of the things that I'm most proud of was our ability to keep our staff employed the entire time, even though other facilities, as we know in our area, had to send interpreters home. In regards to translation, we saw a huge increase in demand of translated materials. I'm really proud to say that our translation program has grown over the last several years, but we saw an increase of 67%, just massive growth over the last year. Our team completed over 1,200 translations in 2020, and a lot of that increase was in fact due to materials for COVID. For staffing, we had some struggle with staffing during the pandemic. Interpreters, like any other healthcare worker, are not immune to fears or healthcare concerns caused by the pandemic. We've had a lot of staff interpreters who've needed to take time away for their own healthcare needs or to care for their family members and loved ones. And we've also had less availability of interpreters through the agencies that we contract with as freelancers. And then additionally, because of financial concerns, last spring, University of Washington, UW Medicine decided to furlough almost all employees at the medical centers, including the interpreters, but fortunately that was just limited to 1 week last spring. Our department's last staff meeting was in May. Since then, we've been asked to not congregate in large groups. Fortunately, in March, we started holding daily huddles, which, as the need for communication has somewhat reduced from the beginning, we've been able to just move to be on a weekly basis. We've attempted to record presentations and have our staff watch, although it's a little less productive than is hoped because still most of our staff is working in person and is not based on the computer. They're not working from home or in other remote scenarios. Our medical center found that the highest incident of hospital-acquired COVID among staff was due to eating together in break rooms or the cafeteria. So we've actually been asked to eat alone. We no longer have potlucks, we don't share holiday treats, and back in the spring, so many restaurants and community groups donated meals to us, and that's no longer happening, or at least not in that form anymore. And so all of this has taken a bit of an emotional toll on everyone because we can't socialize as we used to, and that has caused some isolation on our team. As you guys know, interpretation can be a bit of a silo job, and especially that's true for some of my staff where they are the only speaker for their language group. And so our leadership team in our department has tried to really work to check in with staff, try to give little thank yous, certainly shared kudos and other recognition to help people weather this time. In regards to our work with the community, part of what we do as a department is community partnership. Some folks from our team are on local health boards that represent and advocate for their communities. So, you know, just some are like an Iraqi Syrian health board, Vietnamese, Somali, Latinx, there's a number of others. And by this participation, it's given us the opportunity to help get solid information out to the community around COVID. We've been concerned about the disparity of COVID hitting different populations, different LEP communities who've been disproportionately affected. And in fact, during our spring surge, LEP patients accounted for somewhere between 65 to 75% of admitted COVID cases in our facility. That's quite a lot. We still see those numbers remain disproportionately high, not quite as high, but it's still a concern. So we continue with our collaboration in the community to inform and educate. And now that focus is more on disseminating information about the vaccines. In regards to protective equipment, PPE, universal masking was started at our hospital in early April. Later on, universal eye protection was added. In order to communicate with deaf or hard of hearing patients, we've used shields or clear masks. We've had both our staff as well as our agency interpreters be fitted for N95 respirators. Early on, some of our interpreters asked for universal use of gloves, universal use of scrubs, and the employee health and infection prevention teams felt that universal use of gloves actually would lead to a reduction in appropriate hand hygiene. And then in regards to scrubs, we instead talked about, you know, maybe treating your regular clothing almost as a uniform. If you were concerned about taking clothing home, maybe bagging it before you go home, changing before you leave here, in order to help keep everybody really safe and secure. In regards to vaccination, University of Washington or UW Medicine started vaccinations in mid-December with Pfizer, quickly adding Moderna. Our entire department has had the opportunity to receive or decline the vaccine. Similarly, we've given all of our contracted interpreters the opportunity to get vaccinated through us. We also partner with the UW's Office for Healthcare Equity to create virtual town halls in languages spoken by employees and their families so that they could ask questions and get information about the vaccine in meaningful ways. Now, as our state moves to vaccinate the community at large, we're working to support our most vulnerable LEP patients and communities who've not historically had equitable access to healthcare. And as a leader during this crisis, I mean, I know many of you, like you said in the survey earlier on, many of you are either in formal or informal leadership positions, so you know how difficult the last year has been. I became interim manager of our department shortly before the pandemic started, and then I became director during full-blown pandemic time as everything seemed to explode. And so things have been challenging, and because of COVID, because of furloughs, because of financial concerns, I wasn't green-lighted to backfill my supervisory position, which is what I was previously, for several months. So it was challenging. In order to help, I guess, kind of like support myself, I have notes that are stuck around my monitor, and I have a sign up above my monitor that just reminds me to encourage my staff and reminds me to keep moving forward. The only way we're going to get out of this is by continuing moving forward. As I mentioned before, I'm fortunate to have a leadership team in our department, so a group of supervisors as well as our fiscal specialists who work together to guide and support our staff. So I'm fortunate that I don't have to lead in a vacuum. I don't have to lead by myself. And we have some really amazing staff members, as many of my colleagues have said today. So many kudos going out to our staff, people who get really hyped about being in the trenches, doing the hard thing when these crises come up. It's been great to work with people who are so compassionate and caring about their profession as well as their patients. We've learned so much. We continue to do so. And our hope is to continue to carry on providing excellent care and to promote our profession as medical interpreters. Thank you very much for this time, and I will pass it back to our organizers.
Hi, I think I'm going to take over the Q&A. This is Eliana Lobo, and I want to see if I can't get my webcam up and running. There we go. So folks, we have a lot of interesting questions, and some of them are platform heavy in terms of the tech and the pivoting, and some of them are specific as to what online scheduling platforms you're using. So let's jump in. And Michelle, first, some kudos in terms of your cultural sensitivity with regard to providing a modesty area for vaccinating your Muslim interpreters. Great job.
Thank you.
How long did it take you to transfer from the in-person to the iPad, iPhone alternatives? I know we're all asked to do this very quickly during the pandemic. So what was that turnaround time like for you?
It's hard to remember because so many changes happened. But I mean, we were working 7 days a week to try to make things happen. So it was pretty quick. Within a month, we had several ways to interpret remotely. We were gradually going, we still did some in person until we were forced we couldn't do it. So, but it was relatively quick. Again, because of COVID, all the barriers that we normally and all the meetings we have to attend, they were gone. So everything happened quickly. So
Okay, so all you managers out there know that it can be done in a month, but with a lot of blood, sweat, and tears, right?
mhm.
Someone asked, I am not familiar with Blue Jeans, and is that an app like Zoom?
Yes, and we are now phasing out Blue Jeans. It was not able to handle the demand we had. So now I think in the next month or so, Blue Jeans will completely be gone from our health system. So, but that's what we had. We didn't have Zoom when this first started. So,
We've all been zoomed out this year.
mhm.
The next question goes to Kelly. First, some kudos. Well done on your flexibility and resilience. And this audience member says you really hit the ground running. Another audience member wants to know, for St. Jude's staff, what kind of support services or debriefing is offered to interpreters when dealing with such a heavy and complex caseload? Oh, I think you're muted. Kelly, I think you're muted.
Am I?
Oh, there you
Am I
go.
now?
Now I can hear
Okay.
you.
Sorry. Yeah, there is actually a department in the hospital, a program that they call RISE, which is Resilience in Stressful Events. And so the hospital has trained volunteers that are on call 24 hours for any staff member at St. Jude can call and
Wow.
just talk to somebody. Now, obviously, if there is like an acute psychological need, then they're going to connect you with a professional. We also have the employee assistance program with, access to therapy. And so outside of our department, we can lean really on that resilience department. We participated in Schwartz rounds this last year for a couple of difficult cases with patients, and it was good to be included in that and kind of acknowledge the difficulty for us in that. Within the department, a lot of times it's more informal, but it involves coming in and just saying, "Man, that was rough," and taking the time to listen to each other, and kind of as manager, trying to watch people's faces as they walk in and just being like, "Hey, do you need a break? How about you sit this next one out?" And but we do definitely get a lot of support from the hospital.
Thank you for offering that to your interpreters. I wish that were available to all interpreters. And now a very practical question. Are you able to share the online scheduling platform that you use? Do you know the name of it?
Yeah, the company that we contract with is Service Hub, and they've been absolutely fantastic with us. We have a great working relationship with them, and they were able to really customize to exactly what we needed.
Now, this question I think goes out to everybody who works in a children's hospital, which for multiple reasons is my favorite venue to interpret at personally. And it says, I'm not sure if the panelists can actually answer this, but do children's hospitals in general have better funding or access to better funding sources than most hospitals? So I think whenever we interpret at a children's hospital, we're really made aware of the extra effort that is made for patients and families to understand what's happening. And I really wish I could see that same level of service spread out to all health places of healthcare. So what do you think, panel? Do you guys have more money, or are children's hospitals just doing it better? Irma, you're muted.
Are you able to hear me now?
Yes.
Yeah, we have a robust foundation, and children tug at the heartstrings of our community, right? And so there's not only do we have folks in our own staff that donate as employees, but our whole community at every level. I mean, we have Latino community, we have, they have all kinds of money that come in, and they're always looking for community outreach through grants that are out there as well. So I think it feels that way. But when you think of also the commitment of almost 5,000 volunteers, we have them visually everywhere that are supporting people find their way. I can't compare to other places, but I imagine it's those children.
Okay, and someone is asking, what do you mean when you say provider? Do you mean language provider? No, in this setting, when we say provider, we're talking about somebody who provides health care, because there are just too many titles that have expanded beyond doctor and nurse. So any provider, the person who takes your blood or who takes your x-ray or who treats you as an inpatient or who sees you in an outpatient clinic is what we mean when we refer to provider. Okay, Yvonne, for Zoom or virtual remote interpretation, what are the differences? I would say as an outsider that some platforms are HIPAA compliant and others are not, but what is the platform that appeals for a public health site versus the myriad of options available to independent contractors working from home?
Yeah, absolutely. We do utilize Zoom at the University of Washington, and that was something that was already put into place before the pandemic. We didn't use it a lot in medical interpreting, but it was made available for patient care. Harborview is and the University of Washington provides healthcare throughout the entire Northwest region, what we call the WWAMI region. So that's Washington, even a little bit of Wyoming, Alaska, Idaho, and Montana. And so sometimes we'll have patients who are flown here for very specialty care. They're then discharged, they go home, but maybe they have some kinds of care for follow-up that can be done remotely over the phone or video. And so we had already been putting in place resources for that. And there is a form of Zoom that happens to be HIPAA compliant. We find it very easy to utilize, and it also pairs well with our medical record, which we happen to use Epic here. So that's the reason why we use that platform over others.
Exactly. So note to all interpreters working from home, the free Zoom platform is not the HIPAA compliant one. And that tends to be true of any of the platforms that offer free and then gradual steps up in terms of price and features. The free one is never encrypted and HIPAA compliant. And I wish we could go on, but we've run to the end of our time. So I will be copying out all the questions and sending them to you because I always learn a lot from questions from the audience. And I'm going to read out one that encapsulates my feeling and much of the comments that says, "You are all amazing. Congratulations. And thank you so much for sharing." And thanks for that comment, Thaisa. I'm going to turn it back over to Andrea to do the closing bookkeeping announcements. And thank you so much for sharing your experience and what worked and didn't work for you so that more supervisors, trainers, managers of interpreter services programs can glean something from today that will help them in delivering good language access to their patients and families. So last little bit.
Okay, thank you, Eliana. We have a few announcements before we end today. As you leave today's webinar, you'll be directed to an evaluation form to provide your feedback. Also, be sure to visit NCIHC's website for more information and resources regarding COVID-19, including previous webinar presentations. And on behalf of the National Council on Interpreting in Healthcare, we thank you, Yvonne Simpson, Irma Bustamante, Kelly Jenneman, and Michelle Harris for this wonderful panel presentation. Thank you as well to all who attended this webinar today.